In this training video, we will be discussing the S.A.L.T airway system. S.A.L.T, or supraglottic airway laryngopharyngeal tube, is an oropharyngeal airway that may be utilized to facilitate blind endotracheal intubation. S.A.L.T airway has several components. The S.A.L.T airway itself. Now the S.A.L.T is designed in a unique way. It has this distal end that is designed to abut against the corniculate cartilage and thus align all of the airway anatomy. It also has this epiglottic guard, which is designed to prevent the epiglottis from occluding the pathway of an advancing endotracheal tube. It contains this proximal collar, which also serves as a depth indicator ring to allow the rescuer to see that the S.A.L.T has been advanced to the proper depth. Atop of the S.A.L.T is a midline marker. The midline marker is designed to ensure that the S.A.L.T remains midline and does not rotate left or right and thus misalign the airway anatomy with the device. Also contained in the S.A.L.T airway system package is an epiglottic blade. The main function of the epiglottic blade is to cradle the epiglottis and then to indirectly lift the epiglottis. An endotracheal tube securing clamp is also provided. Once the endotracheal tube has been confirmed to be in the proper position, the endotracheal tube securing clamp can be utilized to secure the endotracheal tube. Also contained is a securing strap that can be utilized both to secure the S.A.L.T and the endotracheal tube. The last component in the S.A.L.T airway system is a package of water-soluble lubricating jelly. Now I will discuss the proper procedure for insertion of the S.A.L.T and the insertion of an endotracheal tube in conjunction with the S.A.L.T. First, we'll make sure we have all our proper PPE. The first step of the procedure is to open the airway utilizing manual maneuvers. For a medical patient, this will be the head tilt chin lift. For a trauma patient, this will be the modified jaw thrust. After the patient's airway is open utilizing manual maneuvers, the patient will be hyperoxygenated using a bag valve mask device. If at any time the rescuer suspects that the patient has a complete airway obstruction, the airway obstruction should be removed prior to insertion of the S.A.L.T airway. After the patient has been hyperoxygenated, the rescuer will take the S.A.L.T airway and lubricate the distal end, utilizing the prepackaged water-soluble jelly. The rescuer will then take the epiglottic blade and advance it into the patient's mouth to the base of the tongue. The S.A.L.T will then be gripped between the thumb and forefinger and placed into the patient's mouth behind the epiglottic blade. The airway will then be advanced into the posterior oropharynx until it reaches its proper depth, which is indicated by the depth indicator ring resting against the lips. After that, the epiglottic blade may be removed and discarded. At this point, if the rescuer is just using basic airway management, the S.A.L.T airway serves as an oropharyngeal airway. The patient will be hyperoxygenated, and as soon as practical, the airway securing strap will be placed on the post on either side of the proximal securing collar. If the rescuer chooses to exercise advanced airway management, the patient will be hyperoxygenated and the endotracheal tube will be prepared. A standard endotracheal tube will be utilized during this procedure. First, the rescuer will check the endotracheal tube and make sure that it's functioning properly, checking for any leaks in the cuff. After the rescuer ensures that the endotracheal tube is working properly, the next step is to lubricate the distal end of the endotracheal tube. Then the rescuer will prepare for placement of the endotracheal tube. After the patient's hyperoxygenated for a minute or so, The rescuer will ensure that the midline marker is midline, ensuring that the airway anatomy is aligned properly with the device. The endotracheal tube will then be placed into the SALT airway and advance to a depth between 21 and 24 centimeters. The distal end of the endotracheal tube will then be inflated. After inflating the distal end of the endotracheal tube, the rescuer will reconnect the bag valve device and verify proper tube placement. This is done by conventional standards. The rescuer will observe for chest rise. They will auscultate for bilateral breath sounds. They will auscultate for the absence of epigastric sounds. Also, the rescuer should utilize an end-tidal CO2 detector to ensure proper tube placement. After proper endotracheal tube placement has been verified, the rescuer will secure the endotracheal tube utilizing the endotracheal tube securing clamp in conjunction with the endotracheal tube securing strap. The endotracheal tube clamp will be placed around the endotracheal tube, and the rescuer should note the numerical depth mark of the endotracheal tube, which should be between 21 and 24 centimeters. The tube will be clamped in place, and then the tube securing strap will be disconnected from the post on the proximal SALT collar and placed on the post of the endotracheal tube clamp. Then the strap will be crossed in a crisscross fashion across the back of the patient's head or neck and secured to the opposite post on the other side of the clamp. After this procedure, the rescuer should re-verify endotracheal tube placement. An alternative method to SALT insertion is to preload an endotracheal tube into the SALT. First, the endotracheal tube is lubricated. The lubricated endotracheal tube is then placed into the SALT. The distal end of the endotracheal tube should not protrude past the distal end of the SALT airway. At this point, the SALT insertion technique goes as such. The epiglottic blade is inserted into the patient's mouth and advanced to the base of the tongue. The SALT is grasped between the thumb and forefinger at its distal end and placed into the patient's mouth. It is then advanced into the posterior oropharynx and the epiglottic blade is removed. The depth indicator ring should rest against the lips. At this point, the endotracheal tube is further advanced to the proper depth between 21 and 24 centimeters. The distal cuff of the endotracheal tube is then inflated, and proper tube placement will then be verified. The rescuer will then verify tube placement by ventilating the patient with a bag valve mask and observing for chest rise, auscultating bilateral breath sounds, and auscultating for the absence of epigastric sounds. A colorimetric CO2 indicator should also be utilized to verify proper endotracheal tube placement. At times, the rescuer may encounter resistance when attempting to insert an endotracheal tube through the SALT. This may be due to some laryngeal edema or trauma. If this is encountered, another alternative method to endotracheal tube insertion is the utilization of a tube exchanger stylet. With the SALT airway in place, the tube exchanger stylet will be advanced to the proper depth, and then the SALT will be removed over the tube exchanger stylet. An endotracheal tube will then be placed over the tube exchanger stylet. Prior to this, the rescuer should ensure that the endotracheal tube is functioning properly. After the endotracheal tube is advanced to the proper depth between 21 and 24 centimeters, the tube exchanger stylet will be removed. The distal end of the endotracheal tube will be inflated. And proper tube placement will be verified by ventilating through the endotracheal tube with a bag valve mask. The rescuer should observe for chest rise, auscultate for bilateral breath sounds, and auscultate for the absence of epigastric sounds. The colorimetric CO2 detector should also be utilized when verifying proper endotracheal tube placement. During the pre-hospital phase of care, the SALT airway should remain in place. The SALT helps ensure that the endotracheal tube does not migrate out of the trachea. After the patient has arrived at the emergency room or in the ICU unit, as soon as practical, the SALT airway should be removed. This will discuss the proper procedure for removing the SALT airway. First, the endotracheal tube clamp is released from the endotracheal tube. Next, the 15 millimeter adapter of the endotracheal tube is removed. For best results, a tube exchanger stylet will be utilized. The tube exchanger stylet will be placed into the endotracheal tube and advanced to the proper depth. After this is accomplished, the SALT airway will be gently guided up over the endotracheal tube and the tube exchanger stylet. In the event the rescuer does not have a tube exchanger stylet, the SALT airway can gently be removed over the endotracheal tube. The rescuer should take adequate care to ensure that the tube is not accidentally displaced. After the SALT is removed, then the tube exchanger stylet will be removed and the 15 millimeter adapter will be reconnected. The rescuer will then reconfirm proper endotracheal tube placement. This concludes this discussion of the SALT airway, an oropharyngeal airway that may be utilized to facilitate blind endotracheal intubation.
Intended to be used by trained medical providers, the SALT is also designed for application in blind situations or where there is limited access to the patient. First, ventilate the patient utilizing a bag valve mask. Grasp the distal end of the SALT between the thumb and forefinger and then insert the epiglottic blade into the oropharynx. Now, with blade in place, insert the SALT until the securing collar rests against the patient's lips. Ventilate the patient utilizing a bag valve mask or pocket face mask. After selecting the proper size tube, lubricate the end and insert the endotracheal tube. Insert the tube through the SALT to a depth of about 21 to 24 centimeters. Now ventilate the patient utilizing a bag valve resuscitator and confirm endotracheal tube placement. Adjust the tube as needed to achieve equal bilateral breath sounds. You can verify correct placement of the endotracheal tube by observing for adequate chest rise. Once patient ventilation is achieved, the SALT should be secured by placing the securing strap behind the patient's head or neck and attach it to the posts located on both sides of the SALT securing collar. Adjust the strap to the proper tension. Finally, re-verify that the endotracheal tube placement is correct to maintain the patient's airway. Once it is deemed safe for the EMS worker to begin rescue operations, the SALT may be the life-saving key to establishing an airway in seconds. Practice your SALT technique today. A life could be saved tomorrow.